have this page where you have a lot of busy stuff on it. And it says the day of surgery. Everybody see that? Okay, so when it comes to this page, I'm going to go over some things that are very important. On the left-hand side, you see where it says pre-op routines, and it says explain, review, consent. No, that is not correct. Circle the word explain, circle that word, and then right next to the circle, put MD only, right? Because you know you ain't gonna explain shit. You are witnessing and reviewing, but you ain't gonna do the actual consent. Okay. Alrighty. Now, if you go down a little bit, you see where it says post-op routines. What is the most important post-op routine the patient's gonna need to do? Cough and deep breathe. So write it. We want make sure you write that. Cough and deep breathe. If you go down a little bit, it says activity out of bed, and right next to it, it says ambulation. So I'm going to give you a patient. Your patient had surgery at 11 p.m. It was a radical mastectomy. They had a radical mastectomy at 11 p.m. They were scheduled earlier, but there was a full collision, 16-car pileup, middle of the winter time, and so they didn't get to do this elective mastectomy, radical mastectomy, till 11 o'clock at night, right? Now, your patient is having this surgery. You're the nurse on night shift. You're off at 7 a.m. and then the day shift nurse comes on. When it comes to this patient who just had a radical mastectomy, what time do you anticipate, either for day shift or for night shift? What time on the clock do you anticipate the patient should be up and trying to ambulate? What time do you think, baby girl?
6 a.m.
You want to do it at 6?
6 to 7.
6 to 7.
7 a.m.
7 a.m.
4.
4. Okay, we say, and you need to write ambulation. You need to write right next to that word ambulation within 6 hours. If it's after, you're negligent. So she had it at 11. So your thing is that she needed to be, you're the closest. She needed to be ambulating by 5 a.m. It may sound crazy because it's going to be in the middle of the night that you're trying to get this patient up, and you will feel like a piece of shit because she's going to make you feel like a piece of shit, and she's going to refuse and all the stuff that goes with that. But you're the nurse. You can convince anybody to do anything almost. And so you're going to have to work your magic. Also, this comes into play with pre-op, which is why you tell the patients the most successful way to have this surgery is to remember within 6 hours of the surgical time, you have to have been out of bed at least once. Okay? So within 6 hours. Now, are you walking them to the mall? No, your first act of getting a patient out of bed is actually to have them sit in a chair. You do not leave them in that chair longer than 20 to 30 minutes. And you commend them and shout hallelujah and hug them and put them back in bed with a warm blanket and say, we'll get you up a little later, but you did it. You did it. And I know that was the hardest thing you ever did, but you did it. Okay, now if it's an ortho surgery, like a hip replacement or a knee replacement or something like that, physical therapy will be the first to get them out of bed. But if you are somewhere and physical therapy called off, it may go back on you. So we have seen that where physical therapy didn't come, and now the patient never was gotten out of bed, and it happened in my family, so I went off. Okay, so what are we trying to prevent?
Re-injury.
What are we trying to prevent when we get a patient out of bed?
Blood clot. Yeah.
That clot I just told you about, right? We're trying to prevent a PE, which will kill you, or a DVT. We're trying our best to prevent that, okay? All right, so you got it. Remember Denny on Grey's Anatomy. All right, now, so if you go down to the very next line, it says pain control. I want you to put a couple notes there. Number one, anytime you give a pain medication, you have to reassess in 30 minutes to an hour. Reassess in 30 minutes to an hour. Anytime you give a pain med to anybody. Like, how do you know it worked, right? The second thing I want you to put, because most nurses forget this, is that substance abusers need more. Substance abusers and even alcoholics require more meds. We talk about this all the time at work. We had a patient literally getting high in the bathroom. And he admitted it. He was real sweet. He said, yeah, I was so nervous I had to hit a joint before I come in here. Okay, great. Now it's going to take me a lot to sedate you. So anytime you're using substances regularly to alter your little mindset, it's going to take me a minute to sedate you. It's going to take me more medicine to get you to feel the way I need you to feel comfortably for this procedure. Okay, so that's something a lot of nurses don't know. Remember the term ATC. ATC, when we're talking about pain meds, means around the clock. ATC. We do this with cancer, with burns, most of the time with post-op. And what we're talking about here is that we are doing the medications around the clock in a way that is not PRN. So if you're ordered something every 8 hours, we're going to give you that pain medicine. It's the opposite of PRN, as needed. We are trying to never let you get too uncomfortable. You'll see us do this with children as well, okay? You'll see us do it with children as well. It's for severe pain. Now, if you go on the right-hand side of the page, up at the top in the middle, you see the informed consent. We don't remove nail polish anymore. We got really good pulse oxes. We don't do that. We don't remove makeup. Everything else is fine. On the right-hand side, where it says nursing considerations, and then more in the middle of the page, I want you to look at two different things. You see it says regional, and then it says general. Everybody agree? With no matter what type of anesthesia we're giving the patient, it doesn't matter which kind, hypotension is the #1 complication. Hypotension is the #1 complication of any type of anesthesia. So since we know that going in, we do what we call a preload, and it might be on there. Yeah, it is. Well, no, I don't know. I don't think the preload is on there. So put the word preload, y'all. Preload with 500 milliliters of fluid, isotonic fluid. Let's get fancy. Preload with 500 milliliters of isotonic fluid. Give me an isotonic IV fluid. Normal saline. What's another one? Lactated ringers. Know those. Write them down if you need to. So NS, 0.9%, or LR. It is really raining hard, y'all. You hear that? All right, so if you are preloading your patient with 500 milliliters of normal saline or lactated ringers, that is going to protect their blood pressure from dropping. The key is that that preload must be immediately before anesthesia is given. And I do mean immediately. So if you think you preloaded them an hour ago when they first came in, that ain't gonna be good enough. They're gonna need another preload. Now, you also see the category of regional on this handout. Regional anesthesia is 2 different types. epidural, and subarachnoid block. So epidural and subarachnoid block. Now you're gonna laugh. Subarachnoid block, I swear up and down that name was changed to protect the guilty. What I mean by that is, for all these years in the history of anesthesia, we have always called this a spinal. Now they done turned around and called it some fancy shit, talking about subarachnoid block. That's because the spinal has a bad reputation in the United States. In fact, I remember when I was pregnant with my first daughter, my great-grandmother told me, child, don't let them give you no spinal. They're gonna paralyze you. Now I thought when they kept offering me the epidural that was the spinal, and I kept hearing her in my mind, don't let them give you that spinal. Shit, I would have took a neck brace and a surgical tooth removal if it would have took away the pain. So eventually I got the epidural, and I was so mad at myself for not saying yes well in advance, because it wasn't the same. And the nurse explained that. My grandmother told me not to get this one. She's like, no, this is not a spinal. So you don't know what your patient is thinking. The subarachnoid block is a spinal. So you figure like this. People might come in and have in their mind they don't want a spinal, but then the anesthesiologist comes in and say they're going to get a subarachnoid block, and they're like, okay, because they don't know what that is. And I think that's by design. Now, when it comes to regional anesthesia or the epidural or the spinal, they both have the same risk. Obviously the blood pressure issue, because we just talked about that. But the other issue with the epidural or a spinal is going to be a spinal headache. With an epidural, it turns into a spinal headache if the epidural goes wrong and becomes a spinal, which can happen. The spinal is just point blank a risk of a spinal headache. What you got to know about this spinal headache, and please make sure you write this fancy $4 word, is that it's debilitating. What does debilitating mean? What does that word mean? So one of my things I say when I did my PhD, the focus of the PhD was to look at how nurses fail their NCLEX, not because they don't know nursing, because of vocabulary and reading comprehension. Now, debilitating is not necessarily a nursing term, but it is a word you gotta know. So what do you think it is?
You're gonna be really affected in a negative way from it. Like your body shuts down.
Well, what I always say with words you don't know, especially when you take the test, is look at the word itself. See if you can figure it out just looking at the word. Debilitating. What's in the middle of it? Debilitating. Doesn't it look like ability is in there? It's disabling. You don't have any ability. You can't take care of yourself. You can't take care of your baby. You can't shower. You can't eat. You can't get up. You can't go to work. You can't, no activity or no, you have inability, right? Debilitating. So that's how you look at these words and figure out, oh yeah, this makes sense. In other words, you have the inability to do anything at all. And that's really something that you want to remember when it comes to maternity. Because with maternity patients, if they get a spinal headache because the epidural kind of went wrong, if they get this spinal headache, they are unable to care for themselves or their baby. It's debilitating. In other words, this patient can't get out of bed. As soon as they move, their head is bursting. They can't even get up. So it's a debilitating headache. Now, with this type of headache, there are lots of things, basic care and comfort and treatments you gotta know. Number one is lay flat. So they need to be supine. And a lot of times we'll say for 8 hours. Supine for 8 hours. So this is why we didn't like, okay, this patient can't do shit. They gotta be supine for 8 hours. Oh my God, what you gonna do? And you flat. The second thing is hydration. So push fluids. The third thing, and this is getting more into medicines and over the counter, NSAIDs and caffeine. NSAIDs and caffeine. So a spinal headache, you treat it with laying flat, push fluids, NSAIDs, caffeine. Now, if none of that works, there is a last resort. The last resort is called a blood patch. The last resort is called a blood patch. This is where we take blood out of your arm and we push it into the hole of your back where the spinal or the epidural was done, and it clots off the leak. Because remember what's happening. This patient is leaking cerebral spinal fluid, and it's causing an imbalance of fluid in the meninges or the brain, because cerebral spinal fluid goes up and down your spine, but it also bathes your brain. It's called meninges. Meninges is the covering of the spinal cord, the covering of the brain. It's massaged and lubricated with this cerebral spinal fluid. Now they done sat up here and put a spinal or epidural in your back. It's leaking fluid into the space. You are getting a debilitating headache, okay? So if we take that hole that we went through, and not we, I shouldn't say we, who does the blood patch? Anesthesia. Anesthesia, not the surgeon, not you and me. Anesthesia has to come in and put the blood in that hole. The blood he just drew out of your arm, he has to push that into that hole in your back and let it clot off the leak. And guess what? It's instantly effective. The headache disappears the minute he's done. It's kind of crazy. Okay, so within 15 minutes, there is 0 for pain level, and you was at 10, because this is the worst headache anybody's ever had. Okay, all right. Now the other thing about regional anesthesia, the last thing, is itching. It itches, so a lot of patients will scratch themselves to death. You'll see fingernail scratches all up and down their belly, because if they're pregnant, that's where they scratch at most. So they're just like tearing their skin up. And they can't feel themselves really tearing their skin up because the epidural is making you numb. It makes you numb from the waist down. So you doing this and you don't feel this. So you're digging holes. I done seen so many scars from just scratching to death. The last thing, it's not a side effect, it's something for the nurse to watch on regional anesthesia. Monitor the bladder. So we monitor the bladder because when you have a regional anesthetic, you can't feel yourself to pee. So you monitor the bladder. Make sure the patient's bladder does not get too full. When you are pregnant and your bladder is filling up, it's hard to monitor it. So you're really just kind of looking at when's the last time she peed. You're trying to encourage her, if she's in labor, to void every 2 hours. If she's not pregnant and you're worried about a bladder, sometimes you can palpate a bladder. It would percuss, use that word. A bladder would percuss as dullness. Percuss. P-E-R-C-U-S-S, percuss. It would percuss as dullness. We have bladder scans. Don't forget, use a bladder scan. It's an ultrasound to check for a bladder. Now, under the general anesthetic, Why do we keep the patient NPO for at least a few hours? Why did we do that?
Check for the gag reflexes.
Look on the paper under general if the answer is there.
Aspiration.
To prevent aspiration. Highlight that. So they need to be kept NPO. Okay, now there is a big complication. Everybody knows it. And it's called what with general anesthesia?
Respiratory.
It's deadly, it's rare, and it's genetic.
Malignant hyperthermia.
Malignant hyperthermia. Malignant hyperthermia. Malignant hyperthermia. We're going to cover that in the back of this packet, but malignant hyperthermia kills you. But it's genetic. So the only thing I want you to write on this page about that is ask the patient if they have ever had anybody in their family. So ask the patient if they've ever had anybody in their family that has died in surgery or immediately after. Okay. Now the next few pages that we have are real quick. They're basically just pages that I need you to highlight. If you see the next page says analgesia, anesthesia, analgesia versus anesthesia. On the left-hand side, under epidural analgesia, I want you to highlight the word PCA. It's really tiny under there. Y'all see it? Highlight PCA. What does PCA stand for, y'all? Patient-controlled analgesia. Put no Demerol, because you can't put Demerol in there. The other name for Demerol is meperidine. M-E, meperidine. No Demerol allowed in a PCA. Now, patient-controlled analgesia is sometimes the, you'll see the epidural put in, and then they'll have a little pump or whatever. So when it comes to this type of anesthesia or analgesia, sorry guys, not anesthesia, it's analgesia. When it comes to this, we still watch the bladder. It can still give you itching. So highlight where it says urinary retention and itching, because it's already there for you. At the top of the page, underneath analgesia and anesthesia, write this really important note. Anticoagulants are contraindicated Anticoagulants are contraindicated with any regional anesthesia. Anticoagulants are contraindicated with any regional anesthesia. It can give them an epidural hematoma. And this will absolutely lead to paralysis. On the right-hand side of the page at the bottom, you see where it says assess for return of sensation and movement. I want you to write something fancy. paresthesia, because that's that sensation, paresthesia should resolve in 4 to 6 hours. Paresthesia should resolve in 4 to 6 hours after regional anesthesia is discontinued.